Now we can go to second part, which is distribution. So out of ADME study, we have covered A for absorption. After absorption, the drug will come into blood. We have discussed after absorption, the drug has reached the systemic circulation. This is blood. So the drug has reached the blood. Now what happened to the drug? Whether the drug will stay in the blood or it will go to different organs like liver, heart, kidney, brain, etc. So that parameter is called distribution. Now suppose the drug has come into blood and we want the drug to reach the liver. Drug has come into blood and we want the drug to reach the liver. So this process is distribution. Now distribution, it is very clear again from the diagram. If we want a drug to be distributed, it has to cross this membrane. It has to cross this membrane. The drug which can cross the membrane will have more distribution. The drug which are not easily crossing the membrane will have less distribution. The most important factor affecting this will be, yes, it is lipid solubility. So lipid soluble drugs usually have higher distribution and water soluble drugs will have lower distribution. Now suppose this is a drug, it is lipid soluble, it can cross the membrane. Now suppose this is another drug, this is also lipid soluble, can it cross the membrane? The answer is no. Reason? This is big molecule. We know for crossing the membrane, the size of the drug should be small. So if a drug is big, even if it is lipid soluble, it will not be able to cross the membrane. The question is, when we were discussing absorption, at that place we did not discuss about size of the drug. But now we are saying that small molecules will cross, big molecules will not cross. Actually, the drugs are always small molecules, so they can cross. But what we want to say here is, this big molecule is a protein. There are proteins present in the plasma. Albumin, globulin, acid glycoproteins, they are present. So many drugs can bind to those proteins and the property is known as plasma protein binding. Plasma protein binding. Suppose this is a protein and the drug has bound to this protein. Now when the drug bind to this protein, the drug behave like a large molecule. Although the drug is a small molecule, but it has lost its individuality and it behave like a large molecule. So what will happen to distribution? Yes, the drug cannot cross the membrane. The drug will stay in the plasma only. So what will happen? The distribution will decrease. So if a drug has high plasma protein binding, means it will have low distribution. High plasma protein binding means low distribution. Here we can discuss little bit more about plasma protein binding. Now plasma protein binding. If we see that acidic drugs, they bind to albumin, whereas basic drugs, they bind to alpha-1 acid glycoprotein. You can remember that easily. A for acidic drug, A for albumin. So mostly acidic drugs bind to albumin, whereas acid will bind to base. So basic drug will bind to alpha-1 acid glycoprotein most of the times. But how much drug will bind? It will be the property of the drug itself. Some drugs have 90% binding, some have 80%, some have 20%, some have 0% also. So different drugs have different percentage bindings. Now plasma protein binding, it has several clinical important points. So we'll discuss these one by one. First of all, what will happen to distribution we just discussed? If plasma protein binding is high, what happened to distribution, or we can say volume of distribution of a drug? Yes, it decreases. We know if the drug is more bound to proteins, it will stay in plasma. So the volume of distribution decreases. Second, usually, again this is not the rule, depend upon many factors, but if a drug has high plasma protein binding, usually the duration of action of a drug is more. The reason is, the plasma protein bound drug, it serves as a storage site. Now suppose we have given 1000 molecules, the drug has 99% binding. So 90 molecules are bound to proteins. So only 10 molecules can be metabolized. So when those 10 molecules are metabolized, the 10 more become free. and they will keep on producing the action. When those are metabolized and more will become free. So in this manner, the drug will keep on becoming free from the plasma protein binding sites and the duration of action continues. So usually plasma protein binding will increase the duration of action of a drug. Okay. Then third important point is displacement interactions. Displacement interactions means, suppose this is albumin. This is albumin and here some drug is bound. Suppose this is the plasma protein binding site for warfarin. Now the problem is plasma protein binding sites on albumin or alpha-1 acid glycoprotein, they are non-specific. That means at this place only warfarin will not bind. So any drug having protein binding can bind to this place. If we give only warfarin, it is binding here. Suppose warfarin has 99% plasma protein binding. We give 100 molecules of warfarin. So out of the 100 molecules, 99 molecules are already bound to proteins. Only one molecule is free and that is producing the action. We know free molecule produce the action. Now what happens, this person who was taking warfarin and well controlled, this person developed some infection unrelated to warfarin, and to treat that infection, suppose we start sulfonamides. We started sulfonamides. The problem is sulfonamides also have high plasma protein binding, and sulfonamide also bind to same place where warfarin bind, because sulfonamides are also acidic. It also bind to albumin. So now there is a fight between warfarin and sulfonamide for the same place. Suppose at most of the places warfarin wins, but only at one place sulfonamide win. So at that place sulfonamide will bind and warfarin will become free. That means free molecule of warfarin increases. Already we have one molecule free, now one more become free. Now you understand, only one molecule has become free, but what happened to the free concentration? It has become double. So the effect of warfarin will become double. It can lead to toxicity. Yeah? So this type of interactions are called as displacement interactions. If we give two drugs, both have high plasma protein binding, then one drug may displace the another drug and that can lead to toxicity. Clear? Then one more important point is dialysis. If a drug has high plasma protein binding, usually we are not able to do dialysis. Remember, suppose some drug poisoning occur. One method of treating the poisoning is to do dialysis. What we do in dialysis? We filter the blood. We pass the blood through some membrane. So some of the molecules remain behind and rest of the blood we give back to the person's body. Okay? So that is dialysis. So many drug poisonings can be treated by dialysis. But do we do dialysis? Can we do dialysis if a drug has high plasma protein binding? I will ask the question in another format. Do we filter proteins in dialysis? The answer is no. Because if we filter the protein with the dialysis, every person will develop hypoproteinemia after dialysis. So that means proteins are given back. So if proteins are given back, the drug which is highly plasma protein bound will also come back. So dialysis is usually not effective for those drugs where plasma protein binding is high. So dialysis is not effective. We want plasma protein binding to be low. Only then we can do the dialysis. Clear? So 4 important factors which are affected by plasma protein binding, you can easily remember. They start with the D. D for distribution. More binding means less distribution. D for duration of action. More binding, more duration. D for displacement. If two drugs have high plasma protein binding, one may displace the another. And D for dialysis. We cannot do dialysis if plasma protein binding is more. Clear? One more clinical important point we will discuss later on in excretion. If a drug has high plasma protein binding, its filtration will be lesser. Remember, filtration also occur only of free molecules. The bound molecules cannot be filtered. Clear? Here we will discuss how we manage the drug poisoning. So there are various methods of managing the drug poisoning. First of all, we do the basic things like A, B, C. That means maintenance of airway, patency, then breathing, and then circulation. This is the basic for any emergency. Plus, in case of poisonings, there is D also, means decontamination. That means whatever drug is still present in the GIT, we will want that should not be absorbed further. So we can give activated charcoal and many other things. Now, apart from all these things, we can give antidotes. If we have some antidote, specific antidote, we can treat with that. Now, many drugs do not have antidote, and the last option which remains is dialysis. So we can filter the blood and remove the drug. So here we will mainly discuss about dialysis and drug poisoning. First of all, dialysis will be effective in which type of drug? So what should be the property of a drug so that dialysis can be effective in drug poisoning? So logically speaking, dialysis will be effective if the drug is staying in plasma, because in the dialysis we filter the plasma. If the drug is not staying in plasma, most of the drug is present in the tissues, then dialysis is less likely to be effective. So for dialysis to be effective, the drug should have low volume of distribution. That means the drug should stay in plasma. It should have lesser distribution to tissues. Okay. Now, second important thing is, suppose the drug is staying in plasma, but the drug has high plasma protein binding. So this is plasma. Although the drug is staying in plasma, but the drug has high plasma protein binding, means it is binding to albumin, etc. And question is, do we filter proteins in dialysis? The answer is no. Because if we filter protein during the dialysis, then every person will develop hypoproteinemia after dialysis. That does not happen. So proteins are not filtered, they are staying in the plasma. So that means if a drug is bound to proteins, highly plasma protein bound drugs, so they will not be filtered because the proteins are not filtered. So along with the protein, the drug will also stay in plasma. So for dialysis to be effective, second important thing is, drug should have low plasma protein binding also. Clear? The problem here occurs in our topic of volume of distribution we discussed. If a drug has low plasma protein binding, it will have high volume of distribution. One of the major reason why the volume of distribution may be high, because only the free drug can enter the tissues. If a drug is bound to plasma protein, then the drug will not enter the tissue, so it will have low volume of distribution. But important thing to realize here is, the low volume of distribution may be due to many other reasons also. It is low plasma protein binding is just one factor which affect the distribution. If a drug has high plasma protein binding, yes, it will have low volume of distribution. But if a drug has low plasma protein binding, it does not mean that always it will have high volume of distribution. A drug having low plasma protein binding may also have low volume of distribution if it does not have affinity for any particular tissue. If the tissue do not accept a drug, it will not stay in the tissues, so it will stay more in plasma. So the catch is, volume of distribution is affected by many other factors also apart from plasma protein binding. So that means only that drug we can do dialysis which has low volume of distribution as well as low plasma protein binding. Clear? Now you need to remember some of the important drugs for which dialysis is done, and some of the drugs for which dialysis is not effective. So you can remember that easily. There is one MLA, member of Legislative Assembly in my community. He was having renal failure, so he was on dialysis therapy. So I remember that from dialysis is done for MLA. So important drugs for which we commonly do dialysis, these include methanol, lithium, and aspirin. These are the important drugs for MCQs. Dialysis is effective in MLA, methanol, lithium, and aspirin. But for certain drugs, dialysis is not effective. So we remember those drugs as avoid dialysis. Avoid dialysis. A for amphetamines. V for verapamil. O for opioids and organophosphates. I for
imipram, D for digoxin, and D for diazepam. Not only diazepam, most of the benzodiazepines. So dialysis is not effective in avoid dialysis, amphetamines, verapamil, opioids and organophosphates, imipramine, digoxin and diazepam. So these are the important things regarding dialysis and drug poisoning. Clear?
Now, third and very important factor affecting the distribution is presence of barriers. Presence of barriers like blood-brain barrier. Now, we all know this is a brain which is bounded all around by a barrier called as blood-brain barrier. So this is blood and this is barrier. Suppose we want a drug from the blood to reach the brain. So it need to cross this barrier. So if a drug can cross this barrier, it will reach the brain. So it will have more distribution. If a drug is not able to cross the barrier, it will have less distribution. But important thing, if you see the diagram, we have drawn some areas like this area or this area. These are part of the brain. But if we want a drug to reach these areas, they can reach without crossing the barrier. Without crossing the blood-brain barrier, they can reach. So that means in the brain, there are certain areas which are devoid of blood-brain barrier. And such areas are called as circumventricular organs. So the areas in the brain where blood-brain barrier is absent, they are called as circumventricular organs. Circumventricular organs. And one of the most important circumventricular organ regarding pharmacology is CTZ, chemoreceptor trigger zone. CTZ or chemoreceptor trigger zone. And we all know this area, whenever stimulated, leads to vomiting. And as this area is outside the blood-brain barrier, so almost any drug can reach this area because it need not cross the blood-brain barrier. So almost any drug can stimulate CTZ, which can lead to vomiting. So this is one of the very common side effect of drugs, nausea, vomiting. You know, whenever someone asks us side effect of any drug, we almost always start with nausea, vomiting. So nausea, vomiting is very common adverse effect of drugs. But one thing to remember, in the Viva exams or in the MCQs, nausea, vomiting can be caused by any drug except, obviously, antiemetic drugs. Antiemetic drugs will not cause vomiting, they will treat vomiting. Another 8 drugs regarding MCQs you need to remember are antipsychotic drugs. Antipsychotic drugs, they also have antiemetic properties. Like one question which is commonly asked on antipsychotic drugs like haloperidol. They ask all of the following are adverse effect of haloperidol except. So we never think about nausea, vomiting. They write the first option as vomiting and we think that vomiting will be present. But that is the answer. Haloperidol or antipsychotic drugs will not cause vomiting. They are rather antiemetic. So the factors affecting distribution are main factors. Number 1, lipid solubility. If a drug crosses the membrane, more distribution. Number 2, plasma protein binding. If a drug has high plasma protein binding, means low distribution. And number 3, ability to cross the barriers. If a drug can cross the barrier, it will have more distribution. If it do not cross, it will have less distribution. Now, we have discussed about distribution. Now, how to measure it? Like in case of absorption, we measure the mathematical parameter which is called bioavailability. Now, what is the mathematical parameter in distribution? And the parameter is called as volume of distribution, which is written as VD. Volume of distribution written as VD. First of all, the volume of distribution is measured by a formula as amount of drug given by IV route divided by plasma concentration obtained. We give a particular dose of a drug and we will divide it by plasma concentration obtained. That is called volume of distribution. Now, to understand the concept of volume of distribution, we will take an example. Now, suppose we have a beaker which contains 5 liters of water. This beaker contains 5 liters of water. We have intentionally taken the example of 5 liters because We assume this beaker is our body and our body contains 5 liters of blood. So we assume this beaker contains 5 liters of water. Now suppose we dissolve 100 milligram of drug in this beaker. If we dissolve 100 milligram of a drug in this beaker, that will be equivalent to giving 100 milligram dose to a person who has 5 liters of plasma. So if we measure the concentration of drug in water, we can say that is plasma concentration. So plasma concentration in this example comes out to be 100 milligram present in 5 liter. So that means 20 milligram per liter. So if we calculate the volume of distribution, it will be from the formula amount of drug given, which is 100, divided by plasma concentration obtained, which is 20. So volume of distribution comes out to be 5 liter. But this does not happen always. Reason is the water which is present in the beaker is not always pure. Means this water can also contain organisms. We take the second example. Beaker again containing 5 liters of water. But now this beaker contains organisms like it has fish, tadpole, frog, sometimes crocodile. So these organisms represents the organs in the body. That means when we give 100 milligram of a drug, when we dissolve 100 milligram of drug in this beaker, out of the 100 milligram, suppose 50 milligram is eaten by these organisms. 50 milligram is eaten by these organisms. That means the drug has gone into tissues. Remember, in the first example, there was no distribution. All the drug stayed in plasma. But in second example, half of the drug is going to tissues. In our example, half of the drug is eaten by organisms. So only 50 milligram will stay in plasma. If we measure the plasma concentration, it will come out to be 50 milligram, which is dissolving in 5 liter. That means 10 milligram per liter. So if we calculate the volume of distribution, it comes out to be amount given is again 100 divided by plasma concentration obtained is 10. It comes out to be 10 liter. So what difference we notice, if a drug has low volume of distribution, means most of the drug is staying in plasma. There is very less distribution, means it is less amount is going into tissues. On the other hand, if a drug has more volume of distribution, means the drug is going into tissues also. So the name explains volume of distribution means more VD, more volume of distribution means more distribution, means more drug is going into tissues. To confirm this, we'll take third example, another beaker. This also contains 5 liters of water. Again we give 100 milligram of drug. But now this beaker contains a crocodile. Crocodile means an organ where large amount of drug will go. Suppose out of 100 milligram, 90 milligram go to tissues. Very high volume of distribution or very high distribution. So only 10 milligram will be dissolving in plasma. So the plasma concentration in this example will be 10 milligram will dissolve in 5 liter. That means 2 milligram per liter. And we calculate the volume of distribution. It will be amount given 100 divided by plasma concentration 2. That means it comes down to be 50 liter. So we can safely say from this example that if the volume of distribution is high, most of the drug is going into tissues. If volume of distribution is low, most of the drug is staying in plasma. So volume of distribution simply represents distribution. More VD means more distribution, less VD means less distribution. Now we have spent around 20 minutes understanding what is volume of distribution. Now we'll try to understand the clinical importance of volume of distribution. To understand the clinical importance, we'll take the example of a drug called chloroquine. We'll take the example of a drug called chloroquine. First of all, why we are taking the example of chloroquine? Because this is a drug having maximum volume of distribution. Volume of distribution of chloroquine is more than 1300 liters. Now, in case of chloroquine, most of it is concentrated in the liver. So we can say in case of chloroquine, the crocodile is liver. Now, for which purpose chloroquine is used? It is used for malaria. Malaria, we all know, is caused by plasmodium. Plasmodium is present at which place when the symptoms of malaria come? Yes, it is in the RBCs. Now suppose this is a blood vessel. This is liver. Blood vessel contain RBCs. Plasmodium is sitting in the RBCs enjoying here. Now if we want to treat malaria, we have to kill this plasmodium. Now suppose to kill this plasmodium, only 100 molecules of chloroquine are enough. So what we do, we give 100 molecules of chloroquine in the blood. So when the 100 molecules come into the blood, it should kill the plasmodium. It should treat malaria. But this does not happen. Reason? Because all is eaten by the crocodile. That means almost all 100 molecules go to liver. Nothing goes into RBC. So plasmodiums keep on enjoying. So that means malaria will not be treated. So what we do? We increase the dose. We make it 200 milligram. All 200 go to liver. We make it 300 milligram. All 300 go to liver. So we keep on increasing the dose. All the drug will keep on going to liver. But one time will come when the capacity of liver becomes full. That means liver cannot store more than that. So after that the liver will say, I cannot store more. Suppose that capacity is 900 molecules. Liver can store up to 900 molecules. So if we give 1000 molecules, what will happen? 900 will go to liver. It will become full. Now it will not accept more. So rest of the 100 will stay in the blood. Now these 100, when staying in the blood, they will now go into RBC to kill the plasmodium. So now the malarial parasite will be killed. So what we are discussing is, if a drug has very high distribution, the simple dose of 100 molecules is not enough. So we need to give very high dose, around 1000 molecules in this example, so that we can start the action of a drug. So we have to give 1000 molecules so that 100 molecule can stay in the blood to kill the plasmodium. So this high dose, which is required to start the action of a drug, is called loading dose. Loading dose is the initial high dose of a drug given to start the action of a drug. Initial high dose given to start the action of a drug is called loading dose. And obviously the loading dose depend upon volume of distribution. It depend upon distribution. The name itself says, first we need to load the tissues. When we load the tissues, only then the drug will start staying in plasma. So depend upon volume of distribution. And obviously second thing it will depend upon is which concentration we want in the plasma. So target plasma concentration. So loading dose of a drug is volume of distribution multiplied by target plasma concentration. Okay. Now continuing with this example, we have given 1000 molecules, 900 go into liver and 100 come into the plasma to kill the parasite. Now out of these 100 molecules, some molecules will be metabolized. Suppose after 6 hours, out of 100 molecules, 50 molecules are metabolized and 50 molecules remain in RBC. So when only 50 molecules remain in RBC, they will not be able to kill the plasmodium. So that means we have to give more drug to make it 100 again. So we have to give the dose again to maintain the effect. So that dose is called as maintenance dose. So maintenance dose is to maintain the effect. Remember, loading dose is to start the effect, whereas maintenance dose is to maintain the effect. But the question is, do we need to repeat this 900? The answer is no, because liver is already full. So maintenance dose do not depend upon distribution. So maintenance dose depend only on this elimination or metabolism. Whatever is broken, we have to replace that. So that metabolism we measure by another parameter which is called clearance. So maintenance dose depend upon clearance. Loading dose depend upon distribution. Maintenance dose depend upon clearance. Maintenance dose, the formula is similar. It is clearance multiplied by target plasma concentration. So loading dose is volume of distribution multiplied by target plasma concentration, and maintenance dose is clearance multiplied by target plasma concentration. Clear? So with this discussion, we complete our second topic, that is distribution.